Firstly, let me thank you for the great privilege and pleasure to be here. And in the next few slides, we're going to talk about the inotropes following basically the continuity starting from fluids to vasopressor of resuscitation, getting to the inotropes with the same pathway. But no disclosures. So just one slide to target basically that what we are aiming for in the treatment of patient with cardiogenic shock is basically to try to counteract the imbalance of the DO2-VO2 mismatch. And to do so, we use at first and the first instance, the first shot of our treatment is targeting the equation of the DO2, specifically at treatment that can actually improve and act on the cardiac output. And those are actually the inotropes. So when do we have to use the inotropes? Inotropes indications are relatively small and has to be considered. Look at the pyramids of the SKY classification that have been published in the new version the other day, when we are facing a patient standing between the stage C and E, with hypoperfusion reflecting metabolic and biochemical, echocardiographic, and clinical derangement. So basically, we do talk about catecholamines, which is a big family of different drugs. But if we look specifically at the action of those catecholamines, we can actually divide such catecholamines according to the effect that they do have on the three broad components of the myocardial machinery, which are basically the contractile elements and the regulatory proteins in the sarcomer, which are the calcium ion cycling elements in the cell and the sarcoplasmatic reticulum, and the energetic elements, talking about the mitochondria and the cellular substrate. So looking at this classification, we will reach the differentiation between the calcitropes that improve the myocardial performance, altering the intracellular calcium concentration and trying to counteract the swelling that may happen during the cardiogenic shock, as we know by the dysregulation of receptors and pumps. Mitotropes that specifically act on the mitochondria and on the biochemical regulation of fatty acids and the beta oxidation. And those on the mitotropes that act on the myosin and the link between the different proteins in the sarcomer. We got a number of catecholamines that may play these roles, but you do know that the more common ones are the dobutamine. We've been mentioned the dopamine, epinephrine, myrinol, levosimendan, which is just on the edge between the calcitropes and the myotropes, acting specifically at the calcium synthesizers, and some other mitotropes that actually haven't been tried in the specific setting of the clinical cardiogenic shock in the patients. Then this is the molecular and the mechanicistic classification, but we do know also from the previous lecture that the more classical classification pertains to the selection of the receptors. And this is extremely important to keep in mind, because the receptors reflect the effect that we are looking for by using one catecholamines or the other. So the knowledge regarding the selection and the selectivity of each catecholamines to a specific receptor is something that we must know when we are sticking a catecholamine infusion to our patient in cardiogenic shock. So now getting to the evidence, let's start for a statement that have been published in the intensive care medicine, which was an expert consensus of the treatment of cardiogenic shock patient in acute myocardial infarction. Inotropes and vasopressors should be used at the lowest dose for the shortest time possible. So must actually be titrated. Then the context is also important. These agents have different effects at different dosages, and the interpretation of the context and on the effect that we are looking for may give the evidence more difficult. And one thing that must be kept in mind, the catecholamines, or at least those catecholamines, are the ones that we have as endogenous molecular and with a physiological effect every day for all our life. So they are basically life-saving in some situation, and they are intermediate molecular that are actually circulating in our body for all our life. So why they should be used cautiously? Because they may have detrimental effects and drawbacks. And those drawbacks depends on the dosage that we select for the specific catecholamines. There are some studies, pharmacological study mainly, demonstrating specifically the dose-related effects to the specific adrenergic receptor. And when the receptor is active and stimulated by the one inotrope or vasopressor, and when with increasing dosage, there is a switch on the protein pathways, getting the toxic, let's say, effect for the higher dose. And we do know very well this story by the Takotsubo and the stress cardiomyopathies, which are the detrimental effects of the adrenergic drugs, that by the switching of the G proteins may get from a safe and good effect on the cardiocirculatory function, switching to the anti-apoptotic, inotropic, negative, and vasoconstrictive effect, leading to the cardiovascular dysfunction. Getting now through the evidence of the few, I have to say, randomized trial that have been run through the literature in the last 10 or 15 years. There's the one that you all know, was one of the first study randomizing catecholamines in patients with undifferentiated shock, so dopamine versus norepinephrine. It was 1,600 the population. And the analysis that have been run through for the cardiogenic shock on 280 patients with undifferentiated, again, cardiogenic shock, which included myocardial infarction, cardiomyopathy, tamponade, embolism, and surgery, demonstrated that the dopamine showed more pro-arrhythmic effects and increased the rate of death as compared with the norepinephrine. And that was already known since small studies. That was the final confirmation, actually. Again, with norepinephrine, there is a very small sample randomized pilot study randomizing 15 patients with norepinephrine and dobutamine versus 15 patients getting epinephrine, and looking with a cardiogenic shock, and looking specifically at the hemodynamics, metabolism, and organ function. With moderately high dosage of epinephrine that you can see happening in the screen, with a maximum dosage 0.25 micrograms per kilos per minute. You can see that the hemodynamic effect was similar between the two, with a similar effect, increase in mean arterial pressure, cardiac index, but the epinephrine resulted in an increase in the heart rate, in an increase in lactates, and in increase in the PCO2 gap, then worsening actually the metabolism of these patients compared with the other, with a combination of the other two treatments, with moderately high dosages, however. Then another randomized trial that, again, you all know, published on JACC 3 years and a half ago, enrollment of 57 patients, 27 to epinephrine and 30 to norepinephrine. Cardiogenic shock related to myocardial infarction was the context. 2 endpoints: first, safety, incidence of a refractory cardiogenic shock. And the first efficacy endpoint was changing cardiac index, assessed by echocardiography. Lactate level has a metabolic mirror, basically, and mean arterial pressure. Well, results were that the mean arterial pressure and the heart and the cardiac index increased in both without any difference. But again, epinephrine showed an increase in the heart rate as compared to norepinephrine, and a refractory shock in a higher rate as compared to the norepinephrine. Metabolic effects: increase in arterial lactate, increase in the cardiac double product. So conclusion was that epinephrine was worst in terms of a refractory cardiogenic shock and the metabolic effect. What it has to be considered is that the dose needed to obtain and use in such patients to obtain one of the endpoints, mean arterial pressure 70 millimeters of mercury, required 0.7 micrograms per kilos per minute of epinephrine and 0.6 of norepinephrine. With the dobutamine that was concomitantly given to this patient in 66% of the population. So the dosage was high, extremely high. One just mentioned, it's a slide that Susanna Price has shown in her presentation before, about the impact of norepinephrine on myocardial perfusion and critical illness. Again, small sample size, 22 patients, but it was quite interesting because it recalls the pathophysiology of the classical cardiogenic shock that demonstrates, looking at myocardial blood flow, that the norepinephrine may affect in a detrimental way the myocardial perfusion. Then has to be recalled and it has to be explained in a very simple way. We do know that in a patient with a classical cardiogenic shock have very high systemic vascular resistances. Then pushing, again, the endothelial function and squeezing the arterioles and the arterial to get more vasoconstriction may actually have a metabolic and the myocardial detrimental effect. Another quick spot on epinephrine and short-term survival. This is the other paper that has been quoted in the new guidelines on acute and chronic heart failure, along with the OPTIMA-CC trial that I just showed you, published on JACC. A meta-analysis of 16 study on more than 2,500 patients demonstrated that adrenaline was worst in terms of mortality rate. Again, a quick spotlight on the fact that there was 2 limitation and bias. That was the first, epinephrine dosages were not known in any, basically, of the study, for exception of the 3 of them. One is the OPTIMA-CC trial, and the other one is that this study included cardiac arrest patients, meaning those patients received epinephrine in bolus for the out-of-hospital refractory cardiac arrest. Therefore, dosage not known again, and metabolic effect may be mixed and biased. Another paper that has been published couple of months ago, even more, but just a few months ago on the New England Journal of Medicine, looking at the milrinone and dobutamine, therefore, inotropes versus inotropes, this time, not inotropes versus vasopressor. Another 92 patient randomized with cardiogenic shock undifferentiated, again, not myocardial infarction related, but it was also non-ischemic etiology. And they did not see any difference in terms of primary composite outcome, hospital death for any cause, stroke, cardiovascular, or renal events. And actually also the other endpoints in terms of vasoactive inotropic score, which is a very important index for patient critically ill and cardiogenic shock patients, lactate, creatinine, and urine output did not change significantly across these two patients at increasing dosage of milrinone and dobutamine. One mention regarding specific effect of the inotropes on the right ventricle, dobutamine versus norepinephrine. Again, we are comparing a principal vasopressor effect versus a principal inotropic effect of those drugs. In a model animal, looking at the VA coupling of the pulmonary and right ventricular circulation. And unsurprisingly, they found out that dobutamine improved RV-VA coupling as compared with the norepinephrine, combining the inotropic effect and the inodilatory effect of such drugs. Just showing you, recalling to mention the levosimendan in a specific setting of acute decompensated heart failure. It is an old study of made by the group of Alex Mebaza, survived randomized trial, published on JAMA. This patient that, despite an initial reduction in BNP, levosimendan, in the levosimendan group, there was no huge difference amongst the primary and secondary endpoints. As I quoted you before, the differentiation between the mechanicistic regulation and effect of different inotropes. I'm going to show you the atomic trial in heart failure, testing the omecamtiv mecarbil to increase the contractility in acute heart failure. And the primary endpoint was dyspnea improvement. It failed in the short term, but it reached significancy within the 5 days in reducing the work of breathing in patients with acute heart failure. As well, there was a significant change in systolic ejection time, which in turn meant an increase in the stroke volume at high dose, both effects of this drug in patients with acute heart failure. Only trial in the acute setting of patients with cardiovascular issues. Now, how titrate inotropes? That's the evidence. We got a couple of indices. The first one is the non-invasive index to assess the ventricular arterial coupling of the left ventricle. Has been published in the septic shock environment, in mitral regurgitation and mitral clip, not specifically in cardiogenic shock, but more in distributive shock. It has demonstrated actually good result. Is the combination of the ventricular elastance measured by the ejection fraction, which is one of the limitations of this index, and the ejection time, and getting the end systolic pressure multiplied by 0.9 is based on the method studied and published by Chen in 2001 on JAC, on the single beats evaluation of ventricular arterial coupling. This has been tried in distributive shock. And in this cohort, again, Guiacchino and Pinsky demonstrated very nice effect of this index that was actually able to identify whether the major component of the shock was attributed to the circulatory effect in distributive shock or in cardiac dysfunction. And that matched very well to the chosen treatment according to this finding. Vascular, choosing the vasopressor, rather than in patient with septic cardiomyopathy, looking for inotropes to regain the perfusion and the cardiac function. That worked very well, has to be validated in cardiogenic shock patients. The other one is an index that Susanna Price shown before, the total isovolumic time, which is an index validated by Alison Duncan in this brilliant paper looking at the cardiac output limitation in patients with stress cardiomyopathy, with dilated cardiomyopathy. And this was an index actually of activation of ventricular performance and global desynchrony. We tested in cardiogenic shock patient and was the best one to identify the profile, the phenotype in patient with cardiogenic shock. I have to say there is another paper published on JACC, also by Alison Duncan. This is the only index that was able to differentiate between patients with limitation of cardiac output and differentiating between the alteration of, in patients, with left bundle branch block, and the differentiating between these electrical abnormalities due to coronary artery disease or due to intrinsic abnormalities of the conduction function of the heart. So it works very well, it's extremely sensitive. It's basically the sum of the isovolumetric periods of the heart and normalized by the heart rate. It's extremely feasible. So this is the bunch of evidence that we got with the structural study of randomized trial. And this lack of evidence, I have to say, is very well underlined by the last and also the previous guidelines on acute and chronic heart failure. As we can see, all the inotropic agents and the vasopressor, therefore all the catecholamine, are regarded as a very low class of evidence, 2B, 3, 2B. So we do not have enough evidence about what are the role of these drugs, which is different to say that these drugs are killing patients actually. This is also underlined by this very nicely done Cochrane review, looking at inotropic agents and vasodilator strategies for the treatment of cardiogenic shock or low cardiac output syndrome, also in cardiac surgery setting, underline that there is no convincing data and robust data to support the different inotropic and to choose actually which is the best inotropic support for the patient. We do know that the butamine is first choice, is actually based on the small evidence that we do have. The problem is that there are no data from randomized control trial demonstrated the benefit of inotropes because for ethical reasons, there is no single trial using an inactive treatment arms in cardiogenic shock. There are no trials giving placebo to cardiogenic shock patients because it's considered ethically unacceptable. So far, we do know that this time is evolving, this stuff is evolving and changing. So we do know that there are these drugs, these catecholamines, are present in our body physiologically. They have specific effects. They may be detrimental at very moderate to very high dosages, but we haven't been tested at the clinically and low dosages. Catecholamines, keep in mind, must be targeted to the specific receptor, clinical effect that you are seeing for. And in general, coming back to the statement we start with, inotropes and vasopressors should be used at the lowest dose and shorter time possible, at least until the evidence won't say anything different. This is the algorithm of the treatment of cardiogenic shock published on Circulation by Sean Van Dieven. And here, highlighted by the red circle is where the inotropes and vasopressors should stay. At the beginning, they are cornerstone of the treatment to keep the patient alive, to restore perfusion and cardiac output, but also we have to assess promptly whether this is not enough, and don't wait to step up as an approach to a mechanical circulatory support, for example, where the inotropes should be weaned off, because there is something mechanical that is getting the cardiac output and the perfusion of our body. Thank you very much for the attention.